On behalf of the League of Women Voters of Corvallis, I would like to welcome you here this evening. Thank you so much for choosing to spend your evening with us. Tonight's program is being co-sponsored by the Corvallis-Benton County Public Library, and we really appreciate all their help. And I also wanted to recognize those on our program committee who helped put together tonight's program. We have Dagmar Johnson, Lisa Scherf, and then Jody Gill, who provided the refreshments. Our purpose is to provide you with information about how our local community is being impacted by decisions made this year by the federal government related to health care, and to discuss how we might respond both individually and together. We'll start with a brief overview of the League and our national position on health care. After that, we'll do some brief networking, followed by short presentations by each of our panelists. Then it will be your turn as audience members to ask questions. And then we'll present a call to action, then provide some time for small group discussion, and finally, we have a few announcements. So, what is the League? When most people hear the name League of Women Voters, they think of voter registration and candidates forums. And for more than 100 years, the League has been the premier grassroots organization for voter education, but that is definitely not all that we do. The League is a nonpartisan, grassroots political organization that encourages informed and active participation in government. Although we still have the word women in our name, we welcome everyone to join us, regardless of gender expression. We never endorse or oppose political parties or candidates, but we do empower voters and defend democracy through education and advocacy, using our standing positions to influence public policy. Any person 16 years or older is eligible to join the League, and we would love to have you join us if you're not already a member. Simply go to our website, looks like this on the home page, and in the upper right-hand corner is the Join tab. And this is where you can also donate to the League, or if you would like to participate in our annual grapefruit fundraiser, we have a few boxes of grapefruit and oranges left, and I think most of you received a flyer on your chair that tells how you can do that. If you'd like to receive our monthly newsletter, just scroll down to the bottom of our homepage to fill out and submit the form that you see here. At the national, state, and local levels, we have more than 100 standing positions on a wide range of topics, and we use our positions to influence public policy through advocacy to our elected officials. Our positions vary widely, from climate change to housing, from waste management to voting rights, from agriculture to childcare. The League is also known for our work on empowering community members to become informed and engaged. Now, last April, the leadership of the League of Women Voters of the United States declared that our country is in a constitutional crisis, from the flagrant disregard for congressional authority and governmental checks and balances to defying Supreme Court orders. Locally, our League has been sponsoring a series of programs with the theme Restoring Democracy as a means of engaging and activating our community. Tonight's focus on healthcare is our third program in the series. The National League has a long-standing position on healthcare adopted in 1993, following a lengthy study and consensus meetings with leagues all over the country. The League position states that the U.S. healthcare system should provide all U.S. residents with a basic level of quality care at an affordable cost. The position goes on to state that healthcare policy goals should include the equitable distribution of services and delivery of care, advancement of medical research and technology, and a reasonable total national expenditure level. During the past 20 years, the National League has been lobbying for healthcare policy solutions to control costs and and ensure basic care for all. Leagues across the country have been organizing community education projects about healthcare, holding public forums and debates, creating and distributing resource materials, and engaging leading policymakers and analysts. Tonight's program is an extension of those efforts. Now, the current administration has made a number of decisions related to healthcare that have serious implications for people across the globe. Internationally, billions of dollars for life-saving foreign assistance have been stripped away by the current administration, primarily through loss of funding to the U.S. Agency for International Development, or USAID. Countless lives have been lost as critical medical supplies and medical personnel have been eliminated. Here in the U.S., our residents are facing a myriad of healthcare challenges due to the loss of federal funding and changes in healthcare policy. Add to these problems the appointment of leading anti-vaccine activists as our nation's top health official, and the healthcare problems we face seem daunting. Tonight, our speakers will provide you with important information about how healthcare decisions at the national level are impacting us locally, and we'll also explore our options for taking action. But first, we're going to take a few minutes to connect with each other. The League of Women Voters of Corvallis is committed to not only educating our community about the issues that matter, but also building community. So we want to encourage communication right here, right now, as part of this program. So we're going to take just a few minutes right now to talk with each other. So when I give you the sign, please feel free to get up and move around or stay right where you are. Turn to those in front of you or in back of you or next to you, but please use this time to talk to someone you've never met before. In fact, we'd like to challenge you to talk to at least one person you don't know in the next 5 minutes. So let's get started.
Yeah, sure, that'd be great. Very good. And you look very balanced. I have a dedicated orange. It's like kind of disruptor. It's balanced crap. It happened, doesn't it?
That's what united them.
Nice to have them
This is Mark Rampton and his partner Alice Rampton. Is there a way to talk to someone with this?
Trying to talk to someone who's in
So I hate to interrupt these conversations, but I'm going to bring us all back so we can move on with our program. So I'm just curious, how many of you met the challenge of talking to someone you've never met before? Whoa, yay, that's really good. That's great. All right. So at this time, it is my pleasure to introduce our first speaker, Christine Mosbaugh, the primary care director for the Community Health Centers of Benton and Linn counties. She guides operations, care integration, and system transformation. Previously, Christine led organizational strategy, population health initiatives, and community engagement efforts. Christine's career spans public health program management, research, teaching, and clinical operations roles, grounded in dedication to people-centered systems and collaborative problem solving. Christine will be joined by Lacey Molell, the Executive Director of the Community Health Centers of Benton and Linn counties. As a health administrator, she has experience leading operations in critical access hospitals and rural health clinics. Lacey oversees integrated primary care, behavioral health, and dental services. Lacey brings a strong multicultural perspective and a passion for advancing accessible, person-centered care and community-grounded services. Please welcome Christine and Lacey to the podium.
All right, well, thank you everybody for being here tonight. Is that loud enough or do I need to move this up? Move it up. Is that better? Okay. A little more. All right. Like an ice cream cone. Okay, I can do that. All right, I see lots of people perking up. So we want to talk to you tonight about what's happening locally with federal changes and things that are going on, and thought we might just take this opportunity to do an introduction of where we're coming from if you are not familiar with community health centers, or if you don't know that we have community health centers in this community. So starting in 2004, so we just celebrated our 20-year anniversary, the Community Health Centers of Benton County, and then joined with Linn County, were founded. We are a public entity community health center, which means we are actually part of the Benton County governmental structure, but we partner with Linn County and do primary care there. We have 5 sites, a Benton Health Center, a Lincoln Health Center, which are both in Corvallis, a Monroe Health Center, East Linn, and Sweet Home. 2 of those centers are school-based health centers, and they also have community primary care, 0 to seniors, and all kinds of services. We also provide dental care and outreach throughout the communities. So our Benton Health Center has a multiple operatory center. We provide the care at the Boys and Girls Club of Corvallis and have a permanent site at the River Center in Lebanon. And then finally, kind of rounding out our services within the Community Health Center, we offer behavioral health through integrated consultants within our primary care teams, and then are part of the Community Mental Health Program, where a lot of those services are in scope with the Community Health Center. Overall, we serve about 12,000 people across our 2 counties. And we were really excited this year to celebrate the 60th year of the Community Health Center movement. There was lots of fanfare and ideas about how we were going to do this, and we have celebrated, but it's been a strange year to celebrate. Overall, we serve as the community health centers across the U.S. 34 million patients, so that's 1 in 10 people in the U.S. We do that with about 1% of the U.S. healthcare spend, so a lot of services with not a lot of money, and many people who are in complicated situations, rural or geographic, in terms of diagnosis and just other factors in their life. Those services are spread out. You can see that 2023 map of locations across 1,500 locations and 17,000 locations and 1,500 organizations. So that's a little bit about who we are. Hopefully that gives some context for what we're going to share with you next, which is the things that are keeping us up at night. And this is sort of a revolving, varying roller coaster. I don't know. There's analogies out there. But as of today, feels like a really important thing to say because things change day to day, hour to hour.
So we have about 9 minutes left, and usually this presentation, or whenever we talk about these things, we could talk for 45 minutes, an hour and a half. However much time you give us, that's how much time we could talk about it. But we're going to try and focus just a little bit. So executive orders, these slides don't have any information because every day we get new information about the things that are changing. And so it's really hard to prepare ahead of time anything that may go out in a document somewhere because it'll probably be out of date by the time we finish. But so as of today, there have been 217 executive orders out of this administration. And many of those have been focused on immigration, identity-based restrictions, public benefits, and just how the federal programs are to be administered. So I assume all of you guys in this room are very well informed folks. You know that executive orders aren't laws. They are just, coming from the administration, telling their agencies how they expect them to function. But we are a federally funded program. Born out of the Public Health Service Act. Section 330 is where our authority comes from. And we have been given a very specific marching orders that we're to serve those who are uninsured, underinsured. We're unable to deny services for people based off of their ability to pay. So in a lot of states, not Oregon, who has a very robust Medicaid expansion program and really believes in healthcare for everybody. I came from a Midwestern state that wasn't a Medicaid expansion state. FQHCs are really the only space that folks have the ability to access primary care and specialty services. So what happens at a federal level directly impacts our ability to provide services. So a lot of the changes that have been going on directly are creating a lot of operational chaos for us to be able to really understand how to function. And Oregon in particular is just a little bit different because 22%, so there are 32 community health centers in the state of Oregon, and 22% of them are public entity community health centers, which means that they're tied to a local branch of government, and we have different operating roles than nonprofits do. And so we have to really pay attention to the terms and conditions and how those are being implemented on our ward and our statutory authority to function. And so there's a lot of things that are happening, but we're really concerned about the chilling effect that it has on our patients in terms of we have patients calling us on a regular basis, asking us to help them unenroll in Oregon Health Plan or the Healthier Oregon Plan, helping them unenroll in SNAP benefits, unenroll in WIC programs, just any program that is tied to federal funding. Our dental director sent us an email this morning to let us know we had 4 dental patients cancel on Friday because they were just too afraid to leave their homes. So in terms of when we think about what this does to our community and public health, we certainly are anticipating that we're going to see big impacts in the future.
The second thing that keeps us up at night is HR 1. So this budget bill and its impact on insurance coverage. So while we generate revenue and we have some federal funds, when those mixes change and when the rules are constantly evolving and the threats are large and looming, how we kind of prepare for that and are sustainable and stable is really a huge question. We know we can't always plan for everything, but all of the ups and downs and the threats to funding really make it hard to be strategic and move ahead. So since July, when this passed, we really have been paying attention to Medicaid and the timelines for that. Oregon has estimated that close to 280,000 people could lose coverage. Sort of an initial impact is $600 million in lost revenue in a biennium. You know, a lot of this projected out over 10 years, so the numbers are different depending on your timeframes. But it's 22% of the Medicaid population that's served by community health centers, and so this just has a huge impact on our payer mix. Before the Affordable Care Act, we weren't always funded largely by Medicaid, but that's kind of where we've landed. We do value-based care, we look at outcomes, and all of this is really being threatened and shifted with HR 1. And the impact for our community is that if we aren't able to provide safety net services, if we're not that continuity of care or patient-centered space that people can go to, they don't have care potentially in some communities, and even when they might come to us for care, the wait time, you know, the services that we're going to be allowed to offer, and sort of the closures that we'll see across the state are definitely looming. And so preventing disease, screening, you know, getting that low level cost in primary care, dental, and behavioral health, so we're not doing emergency care and urgent care, are really what we're here to do. And without sort of the assistance from not just Medicaid, but also Marketplace, without subsidies, those costs going up, we can assume private insurance will go up, and then how we really support our uninsured just continues to be a question we ask as the safety net.
Our kind of last little thing that we're really worked up about is 330B. And I don't know if you guys are familiar with the 340B program or you've heard about it before, but basically it allows covered entities, which are folks who safety net healthcare providers that have serve a disproportionately large share of folks who are underinsured or uninsured, to be able to purchase drugs at cost, and then they're able to reinvest any revenue that they would get whenever they actually bill insurance for that medication, reinvest it back into the community, into care. Community health centers we have only a few little funding mechanisms that really help us be able to provide care for folks who don't have insurance or who are underinsured. One is a base grant from HRSA, Health Resources Services Administration, and then we have an increased reimbursement opportunity with Medicaid patients. So as our Medicaid population declines, that revenue declines. And then the third is 340B revenue. And so there's two things kind of on the horizon that go into effect on January the 1st that will impact 340B revenue. And one is the Inflation Reduction Act. So those Medicare drugs that are the cost is going to go down. Fantastic. We know pharmaceuticals are a big deal, and we are huge believers that, medications should be affordable and accessible for folks. So we definitely are supportive of that. But how that impacts 340B covered entities, so those are like critical access hospitals, disproportionate share hospitals, community health centers, cancer treatment centers, is that we now are kind of revenue around those drugs that we do spend on reinvesting that into care and services. It's about, it's nearly $1 million swing in the opposite direction for 10 drugs, and it's going to be 60 drugs over the next 4 years. So that's a big thing. But the really big thing that we're worried about is the 340B drug rebate pilot that's starting January 1st, which really takes these same drugs that are, most of them, 9 of the drugs are the Inflation Reduction Act Medicare drugs, and says that we have to now purchase them at wholesale acquisition cost, which means we have to buy them at the cost that the pharmaceutical company wants us to buy it at. And then as we dispense it to patients at a lower cost, 340B cost, then the pharmaceutical companies will do the right thing and reimburse us quickly for giving those drugs out. So that means that we go from spending $118,000 a year on these 10 drugs to having to run into a line of credit of nearly $2 million in a year in order to purchase the same amount of drugs for our patients that we take care of every year. So that's our other thing, and we have, but there's still opportunity for you to talk to your legislators about that one. But that's everything for us. Sorry. If you want to connect, this is our contact information. I know we got a lot to cover tonight.
All right, thank you. Thank you so much, Christine and Lacey. And I hope those of you who want to, we're going to have both oral and written questions later for our speakers. And so if you think you want to write down questions, Dagmar has cards. All you have to do is raise your hand. So that was a lot to cover in a short time. Thank you so much. Our next speaker is Dr. Michael Huntington. Mike attended Oregon State University and the University of Oregon Medical School, which is, of course, now known as OHSU. He was an Army flight surgeon in Vietnam in 1969. Mike received his residency training at OHSU, was a radiation oncologist for 35 years, and was medical director of the Radiation Oncology Department at Samaritan Regional Cancer Center in Corvallis from 1984 to 2006. He was president of the Good Samaritan Hospital medical staff in 1997. After his retirement in 2006, Mike joined Physicians for a National Health Program. He was president of Healthcare for All Oregon in 2012, is currently vice chair of Mid-Valley Healthcare Advocates in Corvallis, treasurer for Physicians for a National Health Program Oregon chapter, and secretary for One Payer States. And you call that retirement, huh? Please welcome Mike to the podium.
Thank you, Annette, and thank you, League, for inviting me to speak. The coming changes to our healthcare system are the greatest since Medicaid and Medicare were brought in 1965. They are the worst in the nation's history. I won't repeat what Lacey and Christine told you. It's all bad news with those executive orders. But I do want to spend a little more time on local physicians and nurses, allied health professionals facing heavier caseloads, more complex patients, and increased administrative demands as organizations squeeze more productivity from staff while at the same time restraining wages and benefits. Reduced funding for loan repayment for rural physicians and incentive programs will decrease, worsening the problem for rural healthcare. This leads to something we call moral injury. Have you heard of that term now? It replaces the old term burnout. Burnout implies it's your fault and we're going to help you with yoga exercises and so forth so you'll get back to work. Moral injury means that you are required by your employer to do things that you know are morally against your ethics. This is happening daily, every day. It's one reason that so many physicians have left clinics, so to speak. And those of us who are on Medicaid, we are facing new eligibility hurdles, work requirement. Arkansas tried this, found out they spent more trying to keep track of who was working and who wasn't than they gained. Also, though there is some grant money to help rural hospitals, but it's really insignificant. It's sort of a token gesture. So all of this means more precarious healthcare employment, reduced access of timely and affordable care across our 3-county region. So what can we do? Speaker never gives bad news without offering a solution. First of all, consider short-term personal protection. In other words, put on your own oxygen mask before you help others. So I would ask you to obtain an electronic copy and summary of your medical record, your diagnoses, your surgeries, and your medications. Do this now as a hedge against losing your primary care doctor. Investigate local telehealth options. And if you're unable to receive useful help from telehealth or from Find a Physician, if you don't like to listen to music for a long time, then I hesitate to say this, carefully use AI to answer some questions you might have about your health. Good AI systems, I see shaking of heads. Good AI systems always give references. You don't quote the AI report, you go to the reference. And do I trust that source? I would say if it's from the American Heart Association or the Academy of Family Physicians, you can trust it. Or if it's from the National Library of Medicine, you can trust it. But I don't think we should feel helpless. Let's at least make good use of this new tool. Now, my main request for you is engage with Oregon's Universal Health Plan effort. In 2023, Oregon took one of many new steps towards a more efficient and fair system by creating the Universal Health Plan Governance Board. This board of 9 members is charged with designing a publicly governed plan to cover all residents in the state. Under Senate Bill 1089, which Senator Gelser helped pass, thank you, the board must deliver a detailed proposal by September 2026 that shows how we will finance and administer a universal health plan in Oregon. The board needs our input now, right now. So on one of your handouts that maybe has not reached you yet, it will give you the details on how to reach the governance board. The board is explicitly required to design a plan that improves population health, is affordable to individuals, businesses, and families, and ensures equitable access for Oregon residents. One step in this direction is that every patient brings the same revenue for the provider. So this is a big step towards reducing inequities. There are committees. Some of the people in this room are on the committees for the governance board, including finance and revenue operations committees. And so we encourage you to keep alert. They may have vacancies on the committees, and you may help by becoming one of those board members, one of those committee members. So please sign up for email updates to give public testimony at monthly board meetings. They're in Salem at the Department of Business and, well, it's 350 Winter Street Northeast. But you can also join online. And the handout, if it gets to you, will give you the URL and the QR code. So the ideal plan that a board could propose is a single-payer plan. The single-payer health plan is a system in which a public or quasi-public entity collects funds for health care through taxes or similar mechanism and pays most or all of the medical bills for the entire covered population. In such a system, there is a single main insurance plan and a single primary payer, even though hospitals, clinics, and doctors typically stay independent in separate organizations. They're not becoming government employees, for example. Now, the primary reason that single-payer healthcare works is that it simplifies payment. So, what is a single-payer plan? Now, this will be on one of your handouts also, so don't be frightened by this. The author of this is Warren George, who is with us tonight in the room, and his wife, Peggy. And the main idea here is that a significant healthcare financial flows go through many middlemen. And you need to know that the residents are on the left side, that's us, and then the healthcare providers on the right. Payments flow to us from us through this maze of diagrams to the care providers. So take a look when this handout gets to you at your leisure. Next, here's a version of a flow chart, but with areas of financial inefficiency shown in red. the total inefficiency is about 25%. Can you imagine running a business anywhere where your administrative overhead is 25%? You wouldn't last very long in a business like that. And most of the inefficiency is in provider billing offices, jumping through hoops. And we are infatuated with something called pay for performance, which adds, these are hoops that people have to go through. Value-based payment is another term for that. So there's a lot of administrative overhead in the providers' offices, but also in the insurance companies. It takes a lot of money to decide who not to care for. And then the next slide. Oh, well, just to point out, the red is indications of financial inefficiency. Those are the areas in our current system that are taking 16% of that 25%. So Warren has given us a diagram of what it might look like under a single payer system. Notice the disappearance of all those lines, and the final one is the most important one. That last single line is the payer to the provider. Dr. Rampton is in the room. He and his office know exactly how complicated it is and how many people you have to hire to figure out how to get paid. So this reduces it to one payer. So how does a single payer plan save money? So compared to other countries, we pay twice as much for our health care. And there's three components to that. There's higher drug costs, higher labor costs, and higher financial administrative costs. Notice that little tiny print there. Single payer will eliminate most of this excess administrative cost. So if we save a third of our overpayments, think of how many more patients we can treat, how many more care providers we can hire. So let's channel anxiety into organized hope. The Optum Corvallis Clinic deal, approved under an emergency process to prevent immediate financial collapse, illustrates how fragile local health care can be when it's driven by distant corporate owners rather than community needs. As other systems have seen, that kind of consolidation can trigger provider departures, moral injury, service cuts, confusion, especially when new corporate systems are imposed. The hopeful message, I know you were waiting for this, is that Oregon is building a different plan, and it needs you to help it happen through this public board with deep community participation. We can do this. We must do this. The invitation is clear to you. Protect yourself and your neighbors during this time of healthcare chaos by using available services that Christine and Janet, Lacey, mentioned to you already. Help each other in your community, be aware of who might need help in your community and your neighborhood for that matter, and keep track of them, be a buddy. So, and then stay in the fight by testifying, organizing, and voting for an Oregon health system that will not abandon people when the next corporate deal or federal bill hits. It will hit. So it's not only aggressively following the North Star, it is also, we are making progress if we prevent more bad stuff from happening. So join us at Mid-Valley Healthcare Advocates. It's a local group founded by Betty Johnson in the 1990s. Mid-Valley Healthcare Advocates has worked closely with Healthcare for All Oregon to design and lobby for legislation that improves healthcare for all Oregonians. Clipboards will be passed around to you, and you can sign up if you wish and be contacted. I know many of you already are getting our emails. And there are many ways you can help. Just getting the word out. If you go around and talk with people, ask them, do you know that Oregon is working on a universal health plan? And they look at you, no. So we need to let people know. And feel optimistic. More than that, hope. We have hope, and that will get us there. The governance board is working hard to have a plan ready when the window opens. I think my window is closing here. Thank you.
Thank you so much, Mike. Well, all our speakers so far have given us a lot to think about, and it is my pleasure to introduce our final speaker, the Honorable Senator Sara Gelser Blouin. Oh, I'm going to give you a long intro here. Who serves District 8 in the Oregon State Senate. Sara earned her BA in History and Education from Earlham College and a master's degree in History and Women and Gender Studies from OSU. She served on the Corvallis School Board from 2001 until 2006 and was sworn into the Oregon House in 2005, where she served until she was elected to the Oregon State Senate in 2014. Senator Gelser Blouin is chair of the Senate Human Services Committee and also serves on the Judiciary Committee, Education Committee, and is a member of the Joint Committee on Ways and Means and the Human Services Subcommittee of Ways and Means. Sara entered public service through the disability rights community. She is a consistent champion for those often not heard or seen in the halls of the legislature. In 2017, Sara was featured as one of Time Magazine's Person of the Year Silence Breakers, and her work on disability and youth issues is regularly highlighted in national print, film, and radio. Please welcome Senator Gelser Blouin.
Thank you. So two things. Oh,
Sorry to interrupt. Is there somebody that has a blue Hyundai Elantra down in the parking garage?
blue Hyundai Elantra in the parking garage. We got someone.
Oh, yeah, it's going to be locked in about 3 minutes.
Oh.
So it rolls down.
Yeah.
One of the things we try and stop in and ask to remind people that does happen. But yeah, if you
Thank you.
on the street, this side door, somebody may have to let her in if they can watch for her. But it's going to take her a couple minutes.
I think that's backwards inflation because I think it used to close at 8. Didn't it? Am I imagining that? Okay. And then the two other things that I have to get out of the way, because I've learned you just have to get the things out there, else they'll live in your mind. One, that picture of me is one name, multiple pounds, and several hair colors ago. But I remember those times. It was before the pandemic. And all I could think of when someone said, hold it like an ice cream cone is, what do you do with an ice cream cone? You lick it. So so I'm telling myself, do not lick the microphone, and I am not going to lick the microphone. All right. So it is always hard to go last because others have already laid out a good framework for some of the challenges that we're facing right now. And I just want to take a moment to go back to something that the first presenters said, because it's real and we really have to think about this. People who are foregoing their health care, foregoing their food benefits, not attending school because they're so afraid that if they leave their house, they won't come back. That is not a hyperbole. It is not making a mountain out of a molehill. It is not an unlikely event for many people in our community. This is an issue that is hitting people of all ages. I spoke today with a judge. There was a child in foster care who was removed last week from our own community and detained in Tacoma, likely to be sent away. These are very real and very scary things. And that makes it challenging when we wrestle with all of these other challenges. In my mind, everything kind of balanced to this idea that we're really living in a world where people will come and just grab you off the street and you'll be disappeared, where a leader of a nation will call my majority leader, a Somali refugee, trash. It's shocking and it's appalling, and it just has to be named over and over and over again, because I know that for me, we all have challenges, and those challenges just pale so much in terms of the real threat to these individuals and to our collective humanity and that moral injury that we all share. And I've wrestled with that a lot because it's hard. I think most people in this room get up every day because you like to help people. And it's difficult to get the calls when there's really like, oh my gosh, how do you even deal with that thing? A few weeks ago, I took a little break. I mentioned this at another town hall, but I keep thinking about this. And my friend on this break, I was feeling pretty guilty that I was on this little trip. And she said, community is like a choir. Somebody has to hold the note while the other person takes the breath. And the choir can't keep singing unless you have people that hold the note and someone's taking a breath, and that person that's taking a breath is then holding the note so that others can take a breath. So everyone here who are part of this series looking at what's happening, make sure that you take the time to take a breath and look around you and see who are the people that really need you to hold the note for them for a minute. So just kind of grounded in that, the challenges that we are facing at the state level from the executive orders, the changes in grant funding, the changes in SNAP, the changes in Medicaid are incredibly difficult to wrap my head around. And one of those reasons is that if you look at healthcare more broadly, you look at Medicaid, Oregon has been incredibly aggressive, unique, and really innovative in the way that we have used Medicaid to not only cover many, many, many Oregonians. I mean, we should be so proud of our coverage rate. It's not perfect. There are many inefficiencies, but you know, we've done the work. I think Oregon as a whole is committed to this idea that everybody deserves health care and everybody deserves food. I think Oregonians made that really clear a couple of weeks ago. But that means that right now, with all of these challenges, all of our systems are reliant on Medicaid. So it's not just our Medicaid beneficiaries, it's not just going to the doctor and getting the care. It's not just the innovative services that our CCOs might provide. You know, Governor Kitzhaber would talk about the air conditioner. It really is the in-home support and care that allows aging Oregonians to age in place, that made Oregon the leader in aging at home and reducing our stays in nursing homes and assisted living. It is that made Oregon the first state in the country to close all institutions for people with physical and developmental and intellectual disabilities. We haven't had those in decades because we serve people in the community. That all of those things are paid for with Medicaid, supported employment for people with mental illness. That is paid for with Medicaid. And now we're even looking at meeting health-related social needs with our Medicaid, housing, the other things that we know kind of pull people together. So we are, and I've got written comments that are due tomorrow around how do we go through these budget reduction lists and decide which important things are more worthy or more important than others. And it's a hard task. And what I am trying to do, the way I'm trying to take that is what would happen if we looked at these reductions instead of as what serves a system. Not that anybody wants to serve a system. I don't think that's the way we start. But if we start with the question, what does it mean for the people that we're serving? How do we take a human approach to looking at a budget? So for every dollar that we pull out, how many other dollars does that generate? Is there a federal match? How many people is that dollar benefiting? And for those people, how many of those people do we have another method to get that same service to them? How many jobs do each of those dollars represent? Because in Oregon, we start reducing services, then we're also reducing jobs, which means we're reducing revenue, which means we're kind of in this death spiral. What's laid on top of that, and this is really important because this was also mentioned in that first presentation, many of these orders and the changes in HR 1 are this magical combination of increased inefficiency, paperwork, and administrative costs to deliver worse benefits to fewer people. Like that just doesn't seem like a MBA kind of plan for moving forward. And then you lay on top of all of that, before this, we had challenges. There was great instability that was introduced into the healthcare system during COVID, and I think it's been hard to come back out of that. We have in this community, I think, really been impacted in ways I had not thought about before by the physical buildings that house our healthcare. So whether that is the physical structure and the needs, just in the literal foundation, like the rock underneath the building of the hospital, or the changes in access to buildings and no longer owning them for the Corvallis Clinic, those things drive other kinds of decisions about how do you keep your doors open. I am incredibly concerned. Is that better? Sorry. I was just trying so hard not to lick it. Okay, no licking. Um, we live in an unusual place in Corvallis. I think we are very different than other places. We're not a small rural area, but we're also not on I-5. We don't have easy access to Salem or to Eugene or to Portland. And so when the news came down a couple of weeks ago that Corvallis Clinic's obstetrics and gynecology is closing in February, along with pediatrics, that's really terrifying, because how do people get to Eugene or Salem to get those services? And if you can't deliver your baby in Corvallis, you can't get that prenatal care. Or once your baby's born, you can't get your well child checks or your vaccinations. How do we address the problem the school district has of declining enrollment because we can't attract families here? And then how do you attract other medical professionals to this place to provide those services? How do you operate a hospital system like Samaritan, kind of gauging through all of these challenges and figure out, you are the last game in town. How do you keep the doors open so that all of us have a place to get care when we have an emergency? And that's where you start to see like life rafts being tossed out, like mergers, acquisitions, affiliations, whatever word that you want to call it. And I do think it is a fundamentally different thing than Optum. But I think there's a couple things about my district that I know really well. One, my district really does not want the Coffin Butte landfill to expand. Strong feelings. And my community really did not want the merger with the acquisition of Optum to happen with the Corvallis Clinic. Just, there's so much unity around that. That is kind of the kumbaya moment. Kumbaya, Coffin Butte and Optum Health. But we live with the reality that we have right now. I want to acknowledge, I've sometimes been critical of Samaritan, and I probably will be again, but I know that when they learned about the issue with the obstetrics and gynecology, they are now is it weekly that there's a meeting being stood up to figure out how do we recruit and retain? And that's not a problem created by Samaritan, but it's one of those reasons why it's so important to have local healthcare. When we had issues with the COVID vaccine coming out, we had that approved, we were ready to go. And I don't know how many of you in this room wrote to me, you'd gone to a pharmacy, you'd called your doctor, and you were still told you couldn't get it, and it was available, and you were over the age that you needed to get it, and you still couldn't get it. I was able to call Samaritan, and that got worked out really quickly. My office, the governor's office, the Oregon Health Authority, we couldn't figure out who to call at the Corvallis Clinic and get a return call back. I never ended up talking to anybody. I got an email back from somebody in Washington State that said that they would look into it. So I remain very grateful that we do have folks who are local here that can respond to us. And that gets me to 11 minutes. I think I had 12. So I would say, what are the things that you can do? These are the things that you can do. One, don't panic, even though it's probably justified. It's like the oxygen masks coming down. If you're hyperventilating, it's not going to fix the oxygen mask isn't going to help. We all need to step up and do what we can, where we can, when we can. And when you do what you can, when you can, where you can, that's enough. The second thing is you need to speak out about the things that you see that make you uncomfortable and the ideas that you have, even if they're creative and new ideas, about how we rethink how we do things, because we can't keep doing them the same way that we are doing them right now. The last thing is communicate with us. Talk to me, talk to Representative Finger McDonald, talk to Senator Starr, Republicans, Democrats, talk to all of us about what you're seeing and what you're worried about. And even though it's difficult when you're talking to us about the things that we should not cut, recognize we have to make it's not an option. We have to cut some things. So I am really wanting to hear from people, recognizing that you're not advocating against anything or saying, gosh, I think this is a wasteful program. But if you think through what makes the biggest difference in this community, how do different programs work together? How would you prioritize? What would you look at? And what's most important, that is what is most helpful to me. And your personal stories too, because that helps make things very, very tangible. And then I'll close with, again, on that take a breath, what you can, when you can, where you can. My favorite place in Corvallis, a centering place I stumbled across with my son. I took him out for a walk during COVID. I think we were all looking for places to walk during COVID that were new and interesting. It's the cemetery up on Witham Hill. And there is a tombstone there. And the epitaph is, "She did what she could." May we all have that as our epitaph at the end. Thank you.
Thank you, Sarah. And I'm going to ask all of our speakers to come and take their places up at the front table. And while they're doing that, I have a few simple guidelines for you related to our Q&A portion of the program that we're moving into right now. So if you would like a question card, raise your hand. We've got a few people. And then when you've got something written down, hold it up, and either Lisa or Dagmar will come and pick it up from you. So whether you're asking your question orally or in writing, please don't make a statement, just get to your question. And if you have a question that you're delivering orally, make it in 30 seconds or less, please. Be brief. Whether you're asking your question orally or in writing, if you raise your hand and I call on you, you have about 30 seconds to ask your questions. And then ask questions related to the content of our presentations. So, who has a question? Yes.
This is for Dr. Huntington. Dr. Huntington, you mentioned some ideas such as relying on quality AI and several other things. But you started by saying something about our healthcare records, our electronic healthcare records, and I think you had a recommendation, and I didn't quite get what that recommendation was.
Oh, thank you. It is a personal step that will protect you if you suddenly get that call that your primary care doctor is no longer available. And you are going to be looking for someone, whether it's through telehealth or find a physician, but it's best if you have that information in your possession and you have a right to that information.
Okay, thank you.
All right, we have a question here for either Christine or Lacey. How do people hear about community health centers?
Oh, how do you hear about it? Well, we don't do a good job of advertising ourselves. We're also public servants, so we don't have a big advertising budget. But community health centers are a big part of the healthcare service delivery in the state of Oregon. Like I mentioned, 22% of us are public entities, so we've got them in Lane County, Multnomah County, Lincoln County, like Tillamook County. Lots of spaces in Oregon, but we serve patients full spectrum primary care, dental, behavioral health services, and we don't deny services for folks based off the ability to pay. So we are taking new patients, always available to serve the community.
And if you have people who don't live here and you'd like to refer them to a community health center, we kind of roll up to a Oregon Primary Care Association, or OPCA. We have a regional group like that supports us as well. This is through our federal grant. And then there's the National Association for Community Health Centers, which is more of our advocacy TA training support, but they have lots of ways that you can find local and across the U.S. resources.
All right. Anybody want to raise their hand with a question? All right, then yes, Peter, hi.
I was waiting.
Go ahead, just speak up.
Okay.
Yeah.
I just wanted to ask Senator Gelser about what your role can be and what's the politics in the legislature concerning the single-payer system. I guess we're kind of waiting for the recommendations to come out, but can you prepare us a little bit about the politics, or have you heard anything about getting the single-payer system moving once that report is released?
I think I think the question was for Senator Gelser Blouin. I'm pretty sure. Is that what you asked? Or
Question, please.
I thought she might know something about the legislature.
the question was any insights into the legislative process related to the single payer, you know.
Difficulties, or what's the problems?
So the question, what are the difficulties, problems, and politics around moving towards a single payer system? I don't know. So after that, I don't know, because everything right now is in such disruptive change in terms of the environment. It may be a very good time for the proposal to come forward because we have to think fundamentally about how we do things in a different way. And I have long believed when we're spending money inefficiently, when we're spending public dollars inefficiently in a system where even when we are at our best, we aren't getting things to everyone, it's like a double sin. Not only are you spending money the way that we don't want that money to be spent, but those are wasted dollars that could be delivering something that people need. It's like the proverbial when you're a child and you need to eat everything on your plate because someone else doesn't have access to food. So I think that it's a good time for the conversation. Whether or not people are afraid of it, I think is the question, and I think it will be a point where we call the question. So it's one thing to vote for a task force, to vote for a report to come forward, and I think it is another thing to really take that leap into doing something that is completely different. I had a conversation last week with a former state official, and she was sharing with me her concern that the math just doesn't math around our healthcare system and our safety net system. We have the lowest unemployment rate we've had. We have more people working than ever before. And despite that, 1 in 3 adults in Oregon are on Medicaid, and over 71% of adults on Medicaid are working, many of them full-time or multiple jobs because the employers won't let them get all the way to full-time. And the question she posed to me was, when we keep talking about reforming the healthcare system, and this could be in collaboration with single payer, I'm not saying this in opposition to single payer, but as we look at doing things differently, is the problem the people that are seeking the healthcare, or is the expense being driven by our public safety system boosting up really profitable companies that build and bake into their business model that public subsidies are going to keep them afloat and build their profits? I think it's an interesting question. And I know Washington State actually called for a study to look at kind of their claims data and compare that to the wages and enrollment of employees at different companies to look at which employers are frequently showing up with employees that are needing to utilize SNAP benefits, housing benefits, Medicaid benefits, and which ones are not. And one of the things that they found was small employers rarely showed up, but the large multi-state name brand employers that we all hear about all the time, they had large numbers of people who were utilizing these public benefits. If we can better understand what it is that's driving the cost, that might help us rethink what are the equitable solutions to figuring out how we structure a system to make sure that everybody is able to access care and basic services.
Thank you. Did you want to add anything, Mike? Did you?
Yes. I would just like us to know about how Taiwan was facing what we were in the early 1990s. And there were people working like the governance board is right now, designing what a universal healthcare system would look like if the window ever opened. They had no idea if it would, or when, or how long it would stay open. But they were working faithfully, including Dr. Chun-Wei Chi from OSU, and Dr. William Shao from Harvard. And the window opened. Chiang Kai-shek's regime was being threatened by the opposition, and the opposition had single payer as its plank. The opposition, the old guard was clever, and they stole the plank. They brought in single payer in 1 year, and within 1 year, 95% of the population was insured. We may be in the same situation right now. We do not know when that window is going to open. Somebody may have a stroke and say, I want single payer and I'll call it Trump care, I'll call it something else. That window can open and we have to be ready, and we will be. We need your input, because this plan needs you to say to the governance board what is important to you, what should be in it, and how are we willing to pay for it.
Thank you. All right, this is a little bit different here. Given that the current administration is particularly attacking bodily autonomy of children and young people in the areas of reproductive care and gender affirming care, do you anticipate current federal funds being cut if Medicaid providers offer those services to children? I can't tell if they're saying Medicaid or medical providers, so it's open.
From a federally qualified health center perspective, yes. I mean, it is not even a question anymore. It's written into our new terms and conditions that go into effect when our new grant cycle happens. And so we're under old rules currently, but we in healthcare, QHCs, community health centers across the state, we're all through our collective organizing groups like Oregon Primary Care Association. We're working with IHN and others, with the county, public health departments. We're trying to really have a conversation about care providers in this tri-county area right here in Linn, Benton, and Lincoln counties, about how can we make sure that we're able to sustain our federal programs, because we rely on them and they provide care for folks, for patients and community members, the most vulnerable folks in our communities. And how can we leverage our care providers that are not reliant on federal grants and terms and conditions. But it's really difficult because, federal dollars touch everything that we do in healthcare, from one way or another, if it's through funding to the state and block grants and then match grants that go beyond that. So we're trying to address that as providers regionally, and also for community health centers, we're trying to have a more of a state approach in terms of how can we make sure our most vulnerable patients are cared for and in the most dignified way.
Thank you.
Can I add?
Yes.
Thank you. And I think that's a challenge that we will end up grappling with at the state level as well. I think already, if you're following the news, the Trump administration is threatening to cut off SNAP benefits to all blue states who are not turning over confidential data. We are not turning that information over. I believe what you'll see in the next year is an assault on our Healthier Oregon program, which uses general funds to provide health care to individuals that don't have documented status. And I think that is a really hard thing, again, as we're talking about how do we manage all of these reductions. Like how do you balance that idea of denying care to an enormous population of people that keeps Oregon's economy running in many parts of the state, and risking the loss of many or most of the other benefits that we have? So I think that is an ongoing conversation. I feel good right now about where Oregon's values are and where our leadership's values are in terms of standing up for all people. I think the other thing that's really embedded in the question on youth too is really recognizing within this administration what is a real assault on children. If you look at what's happening around schools, around mental health, around vaccination, around poverty and SNAP, really, like giving children food, it's shocking and very, very concerning. And that is a group that I think we haven't talked a lot about, but the long-term impact of disinvesting in the education, health, welfare, safety, and nutrition of our children is going to stretch the consequences of this period of time far out into the future.
Thank you. Yes, sir.
Probably because of my ignorance, this is the first time I heard the term community care.
Health center, community health center, yeah.
Is this the same as what Will refer to as county clinic?
In Benton County, yes, it probably is. He said, this is the first time he's heard of community health centers? Is this the same thing that people refer to as the county clinic? Benton County is the grant holder for our grant from HRSA, from Health and Human Services. And so it did start out of the public health department at Benton County as a response to not having enough primary care in the area to care for vulnerable populations. And so we've just grown since then and cover both Benton and Linn counties now.
How many primary care providers are there, and do you provide continuity care?
Yes, we have 12 primary care providers across all 5 of our sites, and we provide continuity of care. Yeah.
Across all 5?
Uh-huh.
So what about in Corvallis? How many?
We have 2 clinics in Corvallis, one on 25th, 27th, yeah, thanks. Right across from the Chintimony Park. I'm new to the Pacific Northwest in that I've been here 3 years and I still have to use my maps to go anywhere. But and then one in South Corvallis at the Lincoln Elementary School. And then another down further south in Monroe that is here in Benton County.
Because sometimes I do refer patients to county clinic. If you are federally supported, I assume you won't be able to see any undocumented immigrant. Is that correct?
So it's complicated, right? Right now it's complicated. And so you are correct in that we're not supposed to. But because of all of the legal action, and we're super grateful to our Attorney General of the state who's been very responsive. We as a small group of community health centers executives went and met with his office as soon as we heard about what was coming down in terms of eligible and I heard what the term is. It's not a great term, right? In terms of ineligible immigrants to be able to receive services. So we're protected still until there is a final, until it works its way through the courts in terms of being able to provide care. We are, though, considered currently under the new rules that went into place on July 28th, by HHS, we're considered a federal public benefit. And technically, in 30 states across the country, they're already unable to see undocumented or ineligible immigrants.
The other piece, just to add in the tensions, is that we, as part of our 330 grant, also have some special funding to provide care for migrant and seasonal agricultural workers, which is not synonymous with immigration status. But we don't have a lot of guidance or support from the federal government, who gives us these grants and these funds, about how they expect any of this interaction with public charge and with, attacks on our immigrant communities and people who are moving across the country, really supporting our communities. So we do have funding to do that work, so continue to do that work, but expect a lot of confusion, tension, and are always hopeful for guidance, and have also been told it's not coming. So
thank you. I'm not sure who this question is for. Do you have any insight as to why insurance companies are backing out of providing Medicare Advantage suddenly in this region? Mike might have an opinion on that, I think.
Oh, you may know that Samaritan stopped working with United Health's version of Medicare Advantage because they were so slow at reimbursement. They simply could not plan a budget with denials and delays, like months of delay. That's why Samaritan dropped that version, but it's other systems are dropping Medicare Advantage for reasons I'm not sure, but I think it is related to this very long delay in payment, because they hold on to it. If they hold on to that money, they make a lot of money on it. So now that I have the mic, Dagmar, would you be willing to start the clipboards coming through?
They've actually come around.
Oh, they've come through. Okay. So that'll help you turn your angst into action, is to help Mid-Valley.
Okay, thank you. Anybody have Dave?
There used to be a lot of private practice physicians, and a lot of them just got together into the Corvallis Clinic. Is there any way to encourage the creation of new private practices, especially OBGYN, since that's not going to be there anymore?
So I think that's a tough question, and I rewind my mind back like 30 years. Is Dr. Rampton still in the room somewhere here? Yeah. Thank you for delivering my baby.
I'll just say one thing in 15 seconds. I delivered babies in this community for 35 years. I don't anymore. When we were delivering, around the turn of the century, we were delivering about 80 to 100 babies a month. That's down now around 40. So we were having fewer babies, and it's pretty hard to sustain 2 OBGYN groups in a town this size with 40 babies, 45 babies a month. So I've been expecting something to happen in the last year or 2 or 3, expecting that one of the 2 groups would say, we can't do it any longer. So it didn't surprise me when the news came of the clinic's OBGYN department. We have a community that does not know how to build small homes that young families can love to come here and settle. So they want to move to Tangent, or they want to go to anywhere else, because they just can't afford to be here. And so we're not having a lot of kids.
Thank you.
Thank you, Dr. Rampton. And Patty's back there too. Wow, everybody's here today. So one of the reasons I was rewinding, my family was with Corvallis Family Medicine when it was still separate from the Corvallis Clinic. And my primary care doctor was Norm Castillo. And Dr. Castillo had very strong beliefs about independent practice physicians and talked to me at length because I had a kid where we spent a lot of time hanging out with Dr. Castillo, Dr. Rampton, and Dr. Alette, who was there at the time, all the folks. But I wish I could go back into his exam room and listen to him again, because almost everything he said has happened. Dr. Fassetti said a lot of those same things as well. I don't know how you turn the clock back, though, and you look at the overhead of getting folks started. It's just very, very difficult, and I think it's become even more difficult for physicians out on their own to meet the overhead costs that come with operating a practice, having the appropriate back office staff to allow you to do the work you're doing. How do you continue getting through your day to see your patients if you've got all the calls that are coming in and you don't have adequate staff in the back to take those calls and decide who you need to pull the person out of the room to talk to? And I know even folks that are with, larger clinics like Samaritan, I know my primary care doctors talked about that, like the real challenge is, what is the support staff? So I think that is a really significant issue. I agree that 40 babies is probably not enough. And I also know that we women need a lot of health care, even when we're not having the babies, and I know that that's difficult. People don't necessarily go and seek that. But the other thing that occurred at the turn of the century when the baby stopped being delivered, and I remember this, it's when Barbara Ross ran for the Senate against Frank Morse. And at that time, we had our family physicians stopped delivering babies, or they were at risk of stopping delivering babies. There was an increase in insurance costs at that time, and that was a huge issue in this community. And I remember it because I was, I had many people in my life that were having babies that all of a sudden didn't know where they were going to go to deliver their baby. So I do think it is a critical issue, and we need to figure out how to get more people to want to have babies in Corvallis if they want to be parents and have babies. Not that we should have people have babies that don't want to have babies. And I do think a big piece of that is housing and access to medical care. So it's kind of that loop, catch-22.
So we have time for just about one more question, and I would like to ask Senator Gelser Blouin, do you have anything you can tell us about, and maybe not everybody knows what this is, about the West Coast Health Alliance?
Yes. So the West Coast, how many people have heard of the West Coast Health Alliance? Of course you have. This is Corvallis. So the West Coast Health Alliance is what it sounds like, an alliance of states on the West Coast that are really pulling together their own advisors. It really started to make sense to me around the time last fall. It seems like a long time ago, but this was like what, 2 months ago, 3 months ago, feels like a lifetime ago, with the COVID vaccines. And one of the challenges is, if you think about the pharmacists, is this me again? No. The pharmacists that, during COVID, you could get your shots at the pharmacy. And what the pharmacist is actually doing is prescribing you that vaccine and then delivering that vaccine. Pretty much everyone has that process, nurses. And the way that works functionally is it goes through their licensing board or their standard of practice, and that standard of practice is based on what the recommendations are from the CDC. But once the CDC takes that off the table, what do you do? Because everything's stuck. You can have all the vaccines in the world sitting over at Rice's, but if we don't have the guidance that allows that Rice's pharmacist to deliver the vaccine, none of us can get that. So what this West Coast Health Alliance is doing is basically taking over some of that work that was done at the CDC to create a non-political, research-based, medically driven advisory board that is able to create these recommendations for the states. And what you didn't see behind the scenes in that 2 weeks of trying to get the COVID stuff off the ground, and you all were fantastic, because Corvallis writes a lot of letters with a lot of detail and a lot of phone calls, and I was sending those all to the person in the governor's office that was working on this, and they were able to track things down pretty quickly. But they were changing the guidance from the licensing boards. They were making changes in administrative rules to make all of those things possible so that you could walk into the pharmacy and get your vaccine. We would not have been able to do that without that West Coast Health Alliance. I think it's a pretty exciting opportunity to think about things. One of the areas that I've been working in for a while is the issue of kids' mental health. And if you remember, a number of years ago, we had this issue of kids being sent out of state and they were harmed pretty significantly, and these weren't really high quality programs. But I'm talking with some of the other folks that have been working on that, including Paris Hilton's group, of what if we could build on that West Coast Health Alliance and look at these states that are regionally close, if we could have some sort of a compact around what are our licensing standards and the expectations, what are our abuse definitions, how do we transport and communicate and do all of these things, and then you could kind of build together, if you had Washington, Oregon, and California, where we know there are certain specialties that we need, and we could break down the barriers to be able to use those specialty or specialized resources across state lines as though they were still here in the state. And that would save each state from needing to have to build onto these things, and it would protect us from some of the things that are coming down from the federal level. So I think that there are a lot of really good potentials that are coming out of that. I think we can look at that as well as with nursing and other allied professionals and occupational therapists, like all of these folks where you can't move across the state lines. And there are new issues with the federal government with the compacts, because you could be held accountable in a compact state, for instance, around reproductive health. If you were in this state that allows you to provide an abortion, for instance, and you go back to the other state, you could all of a sudden find yourself with a criminal charge. So we're having to rethink how we do that. And I think that will be a help.
Thank you so much. So we're going to move in. There have been several calls to action while we've been hearing from our speakers, but our program committee also put together a handout, and I'm going to ask Lisa and Dagmar to pass those out now. We've divided our call to action into two overarching actions. First of all is to participate in democratic processes such as voting, staying informed, thank you for being here tonight, reaching out to elected officials, attending town halls and government meetings, and serving on boards and commissions. I heard Mike several times tonight say, you know, there are spaces on this this new governance board and some of their committees. So some of you may want to think about that. And then secondly is to get connected to help you advocate, or where you can to donate or volunteer. And we've listed 4 avenues for doing so. The first on the handout is Mid-Valley Healthcare Advocates, and they're website is listed there. Then the Oregon Universal Health Plan Governance Board, which is what Mike has been talking about, Benton County Health Department, and the West Coast Health Alliance. So those are all various resources that you can look into. Their websites are listed on the handout. And we really want people to take action. Gathering information is important, but you know, we need to move beyond information gathering into action. So hope you'll take those seriously. So in just a few minutes, we're going to invite you to talk with others as part of a small group, and we have a few questions to get you started. What stood out from what you've heard tonight? What concerns you most about recent changes in national healthcare policies and practices? And ask yourself, what can I do? What can individuals do? What can we do together? You may not be able to cover all these questions because we only have a few minutes to do this, but you can start with the one that appeals to you most. And then we just have some quick guidelines. Listen to those who are in your small group. Show respect by suspending judgment. This isn't a time to try to convince each other of your point of view, but just to share what your primary concerns are and what you might do, and focus the discussion on issues, not on personalities. So what I'm going to ask you to do is to just turn to the people around you and create a group of maybe 4 or 5 at the most. If it's more than that, you might have trouble hearing each other. Feel free to move your chairs out into spaces that are near where you're sitting, and go ahead and get started. And then we'll come back together in just about 10 minutes. So I hate to break up your small groups, but I promised people we'd be out of here by 8:15, and we have a few more things we need to cover. First of all, I was wondering if there's anybody who would like to just share very briefly any insights or any comments that you heard in your group. Lisa, maybe you can use this microphone that's on the... Is there anybody who'd like to share from your group? There was a lot of talking going on. No? Okay. If not, then we will continue and maybe get out a little bit early. All right. So if you would like to continue the discussion that we just barely started tonight, we'd like to invite you to come to one of our discussion groups to continue the conversation. We have an evening discussion group that's going to be on December 10th. That's tomorrow night, between 5 and 7 p.m. at Bodie on First. And you don't need to be a league member to join one of these discussion groups. And then our morning group is going to be meeting December 16th from 10:30 to 11:30 at Stony Brook Assisted Living. And we did these groups last month on our topic, which was immigration, and it was very rich. I went to the morning group and I was really impressed with the discussion that went on. Also wanted to let you know that the League will be sponsoring 2 legislative updates during the legislature's short session, which is coming up in 2026. And our first one will be on Saturday, January 24th in the morning, 10:15 to 11:45 at the Calapooya building over on Research Way. And the legislative updates are co-sponsored by Benton County. Let's see. And then the next program in our Restoring Democracy series will be on Thursday, January 22nd, and the focus will be on food and agriculture. And I hope that you will join us for those. If there was ever a time for members of our community to take action, this is it. The need is so great for us to do whatever we can to help save our democracy, and then to restore those parts of it that are under threat and maybe even make some things better. So we hope you will join us for our January program. And in closing, we just want to thank our panelists and speakers so much. Did you have something you want?
There's somebody in the back who had a hand. I just wanted you to repeat that last date.
The last date?
January 27th, and then you went right up on it. Oh, okay, thank you. Got it.
Oh, okay. All right, sure. Okay, all right, thank you. Thanks again to our speakers, our panelists for spending your evening with us, and thank all of you for attending. We hope you have a great rest of your evening, and if you have a few extra minutes, we always love having help putting the chairs back up on the carts. They don't get stacked here on the floor, but on these little carts. So thank you all so much for being here.